specific source, Monday through Thursday, Friday I do my clinical work. We're so appreciative that you've all come out so early in the morning, taking time out of your busy schedule, including clinicians who I'm sure had to block your schedule as well. So thanks a lot. Starting with that, I want to get a show of hands of people from different organizations as well as different types of work that you're doing. So why don't we start with the different types of work? How about any primary care providers in the room? Please raise your hands. All right, keep them up a little bit. Primary care providers, raise your hands. Keep them up. We want to see everybody. How about behavioral health consultants? Awesome. Okay. How about administrators? Okay. It's not a bad word. Billing staff. Great. Any others that fit into a different category than what I said? Quality, yeah, great, quality. All right. And now let's go by organizations. I tried to be comprehensive with my list here. I know I forgot someone, so that'll happen. But how about from Wheats Family Medicine? Great. And how about La Pine Community Clinic? All right. BMC, Ben Memorial Clinic. Okay. High. Central Oregon Pediatric Associates. Okay. Madras Medical. Okay. Mosaic. Big group. St. Charles. All right. High Lakes. Excellent. COIPA, Central Oregon IPA. Central Oregon Health Council. Okay. Pacific Source. Okay. How about Dr. Burkett's office? Best Care? Any organizations I forgot? Really? What was that?
Oh, it's just
okay, great. And how about any individuals who just came out representing an organization? Can I ask what your interest?
Yeah.
What's that?
Cascade Internal Medicine.
Cascade Internal Medicine. All right, thanks for coming. Before I forget, I did want to acknowledge that Aaron Solomon has a desk over there with information on the prescription drug monitoring program and registration for that. I think that's a requirement that by July 1, is it? All licensed medical providers need to be signed up?
Correct.
Okay, so see her if you have questions about that, please. So this is the first of 4 behavioral learning collaboratives that have been generously sponsored by the Central Oregon Health Council's Pain Standards Task Force and the Oregon Health Authority, which is providing the compensation for our esteemed consultant and speaker for today. I'd also like to specifically call out Dr. Kim Swanson and her leadership to help bring together these collaboratives to the community. So today's focus, as I'm sure you're aware, is on the operational aspects of the successful primary care home that effectively integrates behavioral health into their work. We have 3 more behavioral health collaboratives set up for the remainder of 2018. The next one is just a month away on June 5th, and that's going to be on medication-assisted treatment in the integrated primary care home. So I encourage you not to miss that. We have some good speakers lined up for it. And then our third one later, I think in the summer, is going to be on behavioral health integration and the interface of chronic medical conditions in the primary care clinic. And then the 4th collaborative will be on the collaborative care model, which is a specific model of psychiatric consultation and chronic care that comes out of the Ames Center at the University of Washington, as well as I think we'll scope in some other psychiatric consultation models to that. That'll be the final one of the year to be determined. So today's session is intentionally targeted to help those clinics already participating or planning to participate in the PCH Behavioral Health Integration QUIM grant, or Quality Incentive Metric Grant. This is a multi-million-dollar, multi-year grant. Many of you are already participating in that or are thinking about participating in that. But in addition, it's good if you're here, if you're not even thinking about participating in that, it's really open to anybody in the community any clinic that would like to know more about behavioral health integration in the primary care environment. But you're going to hear some things today that are specific to that grant as well. Excuse me. So Pacific Source has been collaborating with many of our provider partners and other partners in the community to develop fidelity models of integration that are sustainably reimbursed to deliver better care with better outcomes at a higher value, while also improving the provider's satisfaction, the so-called quadrupling. While we've made substantial progress, we still have some good work to do, both as providers and as payers. I'm really proud of the collaboration that we've established thus far and look forward to success through efforts such as these behavioral learning collaboratives, the QUIM grant, additional models of reimbursement that we hope to see in contracts that are even more sustainable, and the Central Oregon Health Council's Behavioral Health Regional Health Improvement Plan Work Group, which is one of the many work groups set up by the Health Council, that just recently decided to commit its allotment of funding, which is substantial. It's on the order of $500,000, to fund a technical assistance position for the community, community-wide, not payer-based. Any clinic, any provider can participate, and this position will be funded for the next 2 years. So more of kind of what you're learning today, but to really continue to robustly increase fidelity and work with the clinics. So we're finalizing that through that work group, and you'll be hearing more about it. And the hiring of that position is likely going to be at Pacific Source, although again, if that's going to be payer blind, and it's for the community. With that, let me go ahead and review the objectives for today, and I'm going to have to turn to those. So our first objective is peer learning and networking for patient-centered primary care home providing integrated behavioral health care. Second objective is learn and share best practices around operational strategies for success. Again, the key here that you'll hear from our speaker is on operational strategies, and then to provide an opportunity for team action and planning. So our agenda today, we'll start with the integrated behavioral health in the patient-centered primary care home that Don Creach will introduce in a moment. This will be a short 30-minute or so talk. She'll cover a lot of material. And then we'll have some small group breakouts on some specific topics. But we'll have scribes, and we'll have team discussions, and then report out on that. Then we'll have evaluation, wrap up, and adjournment, all before 9 a.m. So with that, it's an honor to introduce our speaker today, our esteemed speaker, Don Creach from Creach Consulting. Don lives in Portland, but has come out to Bend and the Gorge quite a bit and working with our organization for the past year or so. I first got to meet Don several years ago when I was consulting part-time for family care and just beginning to get into the integration world. And she was already doing some transformative work for the Children's Health Alliance, where she was working about full-time, almost full-time, and was really instrumental in helping develop some of the standards for behavioral health integration in the medical setting for the state of Oregon. You can see her current clinics where she's providing organizations where she's providing consultation. She has a wealth of information on this stuff. I've learned a whole lot from her. And she's a founding member of the Oregon Primary Care Payment Reform Collaborative. Collaborative that I just joined one of their work groups specific to behavioral health, but they're doing a lot of work at the state level that's synchronous with what we're trying to do here. And then she's also an executive committee member of the Integrated Behavioral Health Alliance of Oregon. Many of you are familiar with that's where we have developed our standards, at least at Pacific Source, that we're using for integration. So with that, Don, I'll turn it over to you and hear what you have to say. Thank you.
Good morning, everyone. Thank you so much for being here on time. You had breakfast, you had coffee, we are good to go. I'm not one for using microphones, and no one's ever really accused me of being quiet. So can you all hear me okay? All right, giving some head nods. But if you can't hear me, please let me know. Also, we are doing a test recording in practicing for the June collaborative. So I'm kind of constrained for the camera from here to here. So like this is my approved area. So I'll be moving back and forth. And I am going to try to speak a little bit louder even than I normally do so that we can catch that and make sure we have some folks from the Columbia Gorge who are going to be participating in the June collaborative. And so we want to make it available for those that can't travel to be here in person. So a little bit about today. First of all, we know this is super early, but you're not going to get to just sit back and have breakfast and coffee. Today's going to be interactive. So therefore, you will get out what you put in. I want to just remind everybody that many of the answers are right here in this room. Not one of us holds all the answers or knowledge or expertise to be able to do this work. Folks are trying to figure this out right now across Oregon. And so we've designed today to be interactive so that you have an opportunity to learn from each other. All of us holds a little piece of the knowledge that's going to help move this work, important work forward. Just like medical home or PCPCH implementation, I really see behavioral health integration as a journey, not a destination. I don't know any clinics who are like, hey, we have integrated care completely figured out, we've got the perfect model, we're doing everything just right. That's not the way this is. It's going to be a continuous cycle of experimenting and working to improve how services are delivered. Lastly, as Dr. Franz mentioned, we want you to leave today with an action plan in hand. So you will have an opportunity to meet with your clinic team at the end, discuss what you've learned today, come up with an action plan to implement at least one thing new or different when you get back to your clinic. So first of all, when I talk about integrated behavioral health, there's a lot of terms that people use, and I always like to get on the same page in terms of terminology. So when I say the word behavioral health, it is an imperfect term. It's problematic for a number of reasons, but it's really kind of used as kind of an umbrella term that encompasses a lot of different things. So what's traditionally known as mental health and substance use. There's also health behaviors and sort of overall psychosocial well-being, as well as developmental disorders and disabilities condition. And when I look at this list, these are all things that integrated behavioral health clinicians can help with in primary care clinic. So again, you'll hear a lot of different words, but when I say behavioral health, I really mean all of these things. We now in Oregon have a statutory definition of what integrated healthcare is, and that's the actual term that's used in statute. And I was a part of developing this and getting this passed in 2015. And so I'm not going to read it, but you can see that it's very specific and outlines a number of different activities. Again, not just mental health, not just substance use, it's health behaviors, it's preventive care, it's stress-related factors, and so it's a very broad definition. That same piece of legislation also established the definition for behavioral health clinicians. So you'll hear a lot of different terms: behavioral health consultant, behavioral health specialist. There's a lot of different terms that people will use. I like to use the statutory definition of behavioral health clinician, which, as you can see, is outlined in who qualifies as a behavioral health clinician in Oregon. So how did we get to where we are today? It was a little bit of orientation. So I've been so privileged to work with Pacific Source on this project now for the past year, but actually a year prior to that as part of that pilot. And I really see Pacific Source's work in this area as these main components. First of all, they're really trying to align their strategy and efforts across lines of business, right? Second of all, they're encouraging a population-based approach to how integrated care is delivered. And so they're aligning with the Integrated Behavioral Health Lines of Oregon standards, which we'll talk a little bit more about, and the PCPCH standards. Third, they've done a lot of work to reduce barriers and optimize fee-for-service payments, right? So eligible clinics are able to use an aging modifier to submit a range of codes for their behavioral health clinicians and don't require pre-authorization. And I can tell you that these are major barriers across many different health plans across Oregon and across the country. And so this is a lot of work that they're doing to try to get at that. Lastly, they've invested in technical assistance and resources, right? So we're here today for the learning collaboratives. I've been able to visit with a number of clinics. I recognize you all. To be able to sit down one-on-one and talk about your clinic and what's happening there and how you can improve. And then lastly, really trying to figure out how to move towards value-based payment. And again, this is an area that I don't think any payers have this all figured out. People are experimenting with different things. And Pacific Source, I really see as a leader in this area. And so just giving you an overview of how we got to where we are today. So in my work, I really get to kind of work with different organizations across Oregon. And when I look around, I really think that we're at the tipping point. So many of you may be familiar with the document that was developed in 2007 that really launched patient-centered medical homes. Okay, this is called the Joint Principles of the Patient-Centered Medical Home. And all of the primary care tribes, internal medicine, pediatrics, family practice, got together and developed a set of standards, or principles rather, that really outline what is a medical home. This was the foundational document that launched patient-centered medical homes on the national stage and then soon after in Oregon. And so in that document, if you read it, behavioral health is implicit, right? It talks, excuse me, talks about, need some water. It talks about a whole person orientation, right? Well, so behavioral health's always been a part of the medical home, right? But it was a little bit implicit, it wasn't explicit. And so in 2014, a group got together and actually produced a paper that was published, really amending it and talking about specifically about integrated behavioral health and saying, hey, I mean, this is one of the most, if you have an opportunity, it's not a long document, if you have the opportunity to read it, I encourage you to do so. But this statement, I think, is really, really powerful. So science has rendered untenable the artificial division of people into parts, particularly mental and physical parts, given that over 1/2 of primary care patients have a mental or behavioral diagnosis or symptoms that are significantly disabling, given that every medical problem has a psychosocial dimension, given that most personal care plans require substantial health behavior change, a medical home would be incomplete without behavioral health care fully incorporated into its fabric. A whole person orientation simply cannot be imagined without including behavioral health together with the physical. So that document is chock full of statements like this that really call out integrated behavioral health as this huge component of the medical home that, again, has always been there, but it hasn't really been built out. And so in Oregon, what we're seeing is really this tipping point where integrated behavioral health is quickly becoming the norm. We are seeing kind of from moving from checking a box, right? So if you think about previous version of the PCPCH standards, if you had a behavioral health clinician on site, check, you met that standard. You didn't need to do anything else. But now we know that there are different ways of organizing and delivering the services that are going to better impact population health, right? And so now we have PCPCH requirements that actually outline some best practices for delivering those services. It's incorporated into, again, both Oregon's requirements and CPC Plus requirements. How many of you are part of CPC Plus? Excellent. So you know what I'm talking about. There's a whole document outlining what clinics are expected to do in this area. We see payers experimenting with payment programs and providing technical assistance that's happening across Oregon. It's going to be, it is a major area of focus for CCO and will be probably even a bigger area of focus for CCO 2.0. So the state is ramping up for the next procurement process for CCOs, and behavioral health integration is a huge component of that. And they're actually specifically looking at a lot at kids, actually. Dr. Franz mentioned Oregon's Primary Care Payment Reform Collaborative, which I've been a part of. So that's a legislatively mandated group. It's basically the table where primary care organizations and clinics and payers, all the payers in Oregon, CCOs and commercial payers, kind of get together, and really the focus is on increased investment in primary care. And one of the, we have 4 subgroups, and one of the, based on what we're working on, and one of them is behavioral health integration, and we meet monthly. And so essentially the group makes recommendations to the Oregon Health Authority and the Oregon Health Policy Board, and those recommendations make it into legislation or perhaps the next CCO procurement process. And so we're working on a number of recommendations to come out of that group. that will inform health policy going forward. So none of this is to say that there aren't still barriers, right? We all know that we've developed a system that has segregated and separated mental health from physical health, and it's going to take us a while to get there to put the head back on the body, right? And this is tough work, and we're unraveling sort of decades of this segregation, right? So I don't mean to say that, wow, we're there, but I certainly think that we've reached a tipping point where this is such a hot topic right now. So you all know this. You all live in this every single day. Primary care is called the de facto mental health system. When we look at the numbers, the prevalence, you all are seeing every single day, both in adults and kids. This is not something where it's the 5% of the most acute patients, right? This is a large percentage of who is walking through your door every day that has behavioral health, right? And so I think when we look at the prevalence and we look at those numbers, not only does that mean, okay, we should integrate behavioral health, but it also means we have to think about how we're integrating behavioral health, right? The delivery model or the operational aspect. So we all know that there is a primary care clinician shortage, right? We have a lot of patients, not enough PCPs. We all know that there's a behavioral health clinician shortage, not enough behavioral health clinicians out there. We all know that there is no shortage of patients with behavioral health needs. So when you look at this equation, and I get paid, the big bucks for doing equations like this, right? This means that we need a different way to think about behavioral health, not as a specialty service for the top 5% of patients, but as a routine part of primary care. And that's really what we're doing here that I think is so exciting, is that we are changing the way we think about and deliver behavioral health. So what does this new approach look like? How are we going to organize, given the shortage of PCPs, shortage of BHCs, the prevalence of behavioral health conditions, what is this new approach going to look like that's going to meet the needs of the patient population without burning out our workforce? Well, as I mentioned, behavioral health becomes routine. It's not a specialty service. This really becomes a part of advanced team-based care. Behavioral health clinicians are practicing side by side with primary care providers and the rest of the care team to provide whole person care. Patients are engaged at the point of care when issues are identified, right? So lots of same-day interventions. This becomes routine. It's not a referral that they may or may not attend at some point in the future. This is, oh, we can help you today with that. There's a focus on prevention, early intervention, and patients' overall health, right? This is not just about mental health. This is about health. I really hope that even with our language, maybe someday we can get to a place where we're not talking about mental health and physical health. It's all just health, right? So that's what this is really about. Given our shortage of the workforce, right, and how we're going to deliver these services, we're going to make them short-term, solution-focused, and evidence-based, right? We're not going to be doing hour-long therapy sessions for an unlimited amount of time with patients. We don't have the workforce to do that. We're going to focus on solutions. It's going to be short-term, maybe 4 to 6 visits. It doesn't mean that you will never see those patients again. It just means for an episode of care, you're going to work through that problem, right, and get to a solution. And maybe that patient comes back, just like when patients see their primary care provider, right? They come in, they have an issue, they work to get it resolved. They may come back in a year or even 6 months or maybe 2 years and have another issue, right? It's the same type of longitudinal relationship. And the team is accountable for the entire panel of patients, right? So it's not just the patients with mental health issues, right? Your team is accountable for all the patients at your clinic, right? Okay, so this is like quick and dirty, how I see it as the three main models for integrating behavioral health in primary care settings. I want to first say that there are pros and cons to each of these, and that the models are not mutually exclusive, meaning that a clinic may choose to implement one or more models, but I think it's important that we are deliberate and intentional about the models, because if we're not, we're just going to kind of be chasing our tails, right? So we're going to be intentional about the models that we're implementing. The first is co-located specialty mental health and substance use care, right? So this looks like traditional mental health care where you're referring to the behavioral health clinician who may have an office down the hall, and the person may schedule an appointment at some point in the future to see that BHC and get ongoing care. Now, while that certainly is better coordinated and less stigma, maybe less barriers for patients to access care, it doesn't have a population health focus, right? Because that clinician, BHC, is limited in who they can see, right? Their caseload's going to get full if they're doing hour-long therapy appointments. They may be able to see 6, maybe 8 patients a day at the most. And also there may be a long wait to get in with that person, depending on how full they are, right? The collaborative care model, which Dr. Franz mentioned at the beginning, is another model that came out of the University of Washington Ames Center. And we're going to, as Dr. Franz mentioned, we're actually going to be doing a collaborative on that later in 2018. So I'm not going to go over this a lot, but this is an approach that's evidence-based, using a care manager and a psychiatric consultant to provide services for a subset, and more intensive services for a subset of your patients. So perhaps focusing on those with depression or other issues. And it is a more intensive strategy or vertical strategy. Both of these are vertical strategies, right? We're going to focus a lot of intensive resources on a subset of your population. But that model has been shown to be effective for a wide range of disorders, and so it may be appropriate for some clinics to implement this model. It's a very protocolized approach and very specific to how it's implemented, and I think Dr. Franz will tell you it's challenging. There's a lot of challenges to implementing it to fidelity. Over here, what I'm calling integrated care or primary care behavioral health. This is kind of what we've been talking about, right? Integrated behavioral health is routine. The BHC sees a wide range of issues, doing a lot of same-day appointments, a lot of population reach, right? They're reaching a lot of patients. They may see 8 up to 14 patients a day for maybe 30-minute visits or perhaps even less. And they're really focused on improving population health for the overall population of the clinic. So out of this came the Integrated Behavioral Health Alliance of Oregon recommended minimum standards. So this was something that we developed back in 2015. I would call it IBEHAL, Integrated Behavioral Health Alliance of Oregon. Now it's long. We worked for an entire year with stakeholders across the state to come to consensus, which is not easy, but to come to consensus about what does high quality integrated care look like in primary care settings. And so this is what we came to. Most of you are familiar with this by now. And we were very excited because about 90% of this was actually incorporated verbatim into Oregon's patient centered primary care home standards for standard 3C3, for those of you that are familiar with that. So from this, we actually developed an assessment tool. So many of you may remember that Pacific Source was using the IPAT to kind of measure integrated care clinics in terms of where they were at. Well, now that we have IBEHAL standards and they're incorporated into PCPCH, it makes sense to align with those, right? And so we developed an assessment tool based on the IBEHAL standards. And so many clinics have or are in the process of attesting using that self-assessment tool. To be considered integrated, clinics must score at least a 5 on that tool. It goes from 1 to 10 and kind of gives you an explanation of like what that looks like in your practice, and then you self-attest. But you do have to be a 5 or higher on each of the standards to kind of meet the minimum levels of integration. Clinics also have to meet standard 3C3 for PCPCH CPH, and what that is coordination, communication, information flow, and even co-management with outside behavioral health clinicians for your patients that are getting specialty care, right? So this doesn't mean that it's happening for every patient all the time, although that would be awesome if it was. But it does mean that clinics are intentionally trying to track their patients that make it to specialty care and have some level of communication or information flow when appropriate for their patients that are receiving specialty care outside of the medical. And then clinic, your self-attestation is reviewed via site visits. So those will be happening later this year. So in terms of metrics, okay, there's some metrics that some clinics are reporting, and I know clinics just submitted their first quarter report for the metrics. And so I did just want to speak a little bit about where those metrics came from. They didn't just totally come out of thin air. The Integrated Behavioral Health Alliance of Oregon in 2016 developed some metrics and really looked to see what was out there. This is cutting edge work. So there's not a lot of standard NQF metrics that really measure integrated behavioral health. So we developed some preliminary measures to kind of put out there for people to kind of choose from and think about, right? And we did a lot of thinking about, you know, how are we going to measure this? And one of the things that comes up is that really getting to like outcomes, you want to measure outcomes, everybody wants to measure outcomes, that's really tough. I mean, y'all don't have $1 million R01 NIH funded research study to measure outcomes, right? Or does anybody have $1 million? Okay, let me know if you do, because we could do some fun stuff. But it really is we need a glide path to get there. Like, what does that look like, right? So let's start with some process measures. That's really what the Idaho standards are, right? They're a process measure that's measuring where you're at on delivering integrated care. Next, we look at intermediate outcome measures, right? So this is things like, I would consider population reach an intermediate outcome measure. So that's one of the things that clinics are reporting, population penetration or population reach, I like to call it. So this is, right, of your patients that are coming into your clinic, how many of those have had a BHC encounter? So are we only, we know prevalence data is indicating 20, 30, 40% of your patients might have a diagnosable mental health disorder. So how many of those are we reaching? Are we reaching 5%? Are we reaching 10%? Are we reaching 20% of those who come through the door? So that's a good, what I would say is an intermediate outcome measure. And then we get to true patient outcomes, which if anybody's totally there, let me know. But like, we got to figure that out at some point, but we're just not there yet. So a number of CCOs, including Pacific Source and Care Oregon and Family Care, which is no longer here, but all those CCOs chose from these metrics, and their clinics in Portland and actually Jackson Care Connect in Southern Oregon and some others are all reporting the same metrics that you guys are reporting, which I think is pretty cool, right? Like, we didn't get every single health plan picking totally different metrics and then the clinic's going crazy, right? Everybody's kind of trying to use these same metrics, which is, I think, a great win. And we're all trying to figure this out together, right? Okay, so these are the 3 metrics that y'all reported on, and we had a call last week, and I know maybe some folks are still maybe pulling together their data, so I just wanted to take a moment and check in with you all in terms of, not that far, the metrics. Does anybody have anything they want to share about their metrics? Good, bad, otherwise, surprising? When you put your numbers together and came up with your percentages, was there something that like shocked you or not? Anyone? I pick on people. Enough coffee. All right, I'm gonna pick on people. All right. All right. Wendy. Wendy's from COBA, Central Oregon. Yep.
So I think it's just good information for us to have, but I think what was surprising to us is there's opportunity for us to really increase access same day. So we were sort of approaching it as like a scheduled appointment, you have to schedule it ahead of time and not really taking advantage of same day visits and turning appointments that we could pull in at the HC at that moment. And I think one of the things to take note is that this model actually allows VHCs to be interrupted in appointments. And when you share that information with the primary care providers, that's really surprising to them. So, but I think that's how you make the model work.
Yeah, part of the reason why we asked like the different representatives to be here from your teams is because this is about team-based care. This isn't about just your behavioral health clinician doing their thing. This actually requires a change from the sort of cowboy or cowgirl to pit crew, right? So your primary care providers are recognizing, oh gosh, I may have dealt with this on my own in the past, but perhaps I could bring my BHC in so that I can move on to the next patient, and the BHC can spend 15 or 20 minutes doing an intervention with that patient. So that's why we've asked y'all to be here today. Yeah?
Well, I think Wendy brings out one of the challenges. I was going to say, I think that Wendy brings out one of the challenges of this model, and that's that it's not a self-sustaining model from a financial standpoint. And so if you allow enough room in your schedule for the kind of the arm grabs, which we need in primary care, it's difficult to support the model financially. So I know that that's part of the focus of what we're doing. I think that that's one of the challenges of allowing for that.
Absolutely. I do have a few slides on that. I don't have it all solved, but I do have a few slides on that. All right. There'll be more time for discussion later. So for those clinics that are participating in the Pacific Source CLIM around this, the dollars are attached to achieving a certain population reach percentage, 5% in the first year and 10% in the second year. And so I thought we could spend a moment talking about strategies for increasing population reach. We're also going to have a small group breakout on that in a little bit, but I thought just as a whole, we could talk about that, right? So here's some that I have thought of, but certainly there might be others, so I'd love to hear from you all. So some ideas. Standardized workflows. So maybe all of your patients with a positive PHQ-9 automatically see the BHC, right? We're not going to wait for PCP referral. We're just going to make it a standard part of care at our practice. All our patients with a 10 or higher on PHQ-9 see the BHC. Or pick your subpopulation. All our patients with chronic pain see the BHC. That's just a standard part of what we do. So that's a strategy to sort of make integrated behavioral health routine, right? And increase your population reach. Next. Maybe you could identify patients for the BHC to see by scrubbing the charts and conducting pre-visit planning. It doesn't have to be the BHC doing this. I would argue that's not necessarily a good use of licensed clinician time, but perhaps the front office staff or an MA can be trained to kind of do some chart scrubbing ahead of time, see who's coming in, say, oh gosh, this patient had a positive depression screening last time. Maybe we'll have to go ahead and schedule the BHC to come in that day and touch base, see how things are going, right? So different ways to kind of think ahead, right? Be proactive about the patients that are coming in. Using a registry. Maybe you have a registry by diagnosis or maybe you have a risk stratification process, right? Maybe your highest risk patients maybe automatically get joint appointments with the BHC when they come in, right? That's something that might work. Maybe you just automatically schedule joint appointments with the PCP and the BHC for certain conditions or certain subsets of your patients, right? When they schedule with the PCP, you're automatically putting them on the BHC schedule. Group visits. Great way to reach a group of patients. Maybe your patients with new ADHD diagnosis all get invited to a group session on ADHD that's led by PCP and maybe the BHC.
Don't bring the kids.
Yeah.
Lots of areas of struggle.
I mean, I think you're bringing up a good point that comes, working in pediatric care. First of all, group visits, that code has never been reimbursable. So there's this conflict between what we're doing in the room and then how we reimburse for that. Like Dr. Canavarian said, and especially in pediatrics where I walk in and we talked about this. I don't know who
patient is at any given time. Is it the parent in the family system, or is it the kid? And how to rectify that from a patient care billing perspective, how to take care of each other. So I don't know if you're going to touch on that today.
Are you guys like dropping hints or something? You want me to talk about that? Okay, fine. Fine, we will get there. All right. So again, these are sort of when I think about financial sustainability, these are really the components, okay? And it's not one, it's not two, it's probably all four. I'm trying to get there, but you got to think about all of these components, right? So first of all, removing some of those structural barriers. So being able to bill certain codes, not having to do prior authorizations, etc. I can tell you that Pacific Source alone is not going to solve this problem. They can be as innovative as they want and do all, because you have all sorts of payers, right? Oregon has a huge number of plans, and I can tell you from our work on the Primary Care Payment Reform Collaborative that they're doing something different. And so part of the work of that group at a state and a policy level is to remove some of those barriers and try to get standardization. As a matter of fact, I put together a list of priority CPT codes that are being put forth as kind of recommendations that all payers cover those. I don't know how far we'll get, but it did make it to the straw proposal. So, but this is larger than Pacific Source. And so we're trying to figure that out. Optimize your fee-for-service revenue. I am just struck by the number of clinics that I go to that their BHCs are not even credentialed and they're not billing for any services. Guess what? Of course that's not going to be sustainable if they're not billing for any services. Or maybe they're using 2 or 3 codes, but that's it. You're not going to get sustainability with that. I think we've got to figure out a way to optimize our fee-for-service revenue. And so there's going to be a small group breakout to talk a little bit more about that piece. There are, as an organization, I hope that you're taking into account cost offsets, right? So these are things, there's evidence that shows that if you're doing this model and your BHC is seeing a large percentage of your patients, that you're going to increase the capacity of your PCPs to see more patients and have therefore more billable revenue coming in from the PCPs. But that's directly related to the behavioral health clinicians. So you got to I don't think you're going to get 100% of the salary and benefits of your BHC back in fee-for-service coding. Probably not going to happen. But as an organization, I would encourage you to think about these cost offsets. And if you're interested in literature on that, I can certainly provide that to you. And last, but certainly not least, value-based payments or alternative payment approaches to pay for this kind of work. There is some work, especially around prevention and early intervention, that is just really hard, that doesn't really fit in a code or a fee-for-service. And think about the other things that your BHC might be doing, the consultations with the primary care clinician, consultations with your nurse triage when you have a patient on the phone who's having a behavioral health crisis. Thank you. I've been instructed to stay within my area. So all of these things don't really fit in a code, right? And so it really does require moving towards a value-based payment approach. But again, I don't think anybody has this figured out. People are experimenting with things. Pacific Source is trying to figure it out. But this is a tough area, but it is where we're going next, right? So I touched on this, and I'm going to go really quick so we can get into our next component of the agenda. But these are all the things your BHC might do, right? These are all the different categories. Screening and prevention, collaboration and consultation, health behavior intervention, patient-family engagement, care coordination, treating mental health concerns, chronic disease management, crisis management. So ideally, we would have CPT codes that kind of match with all these different services, right? Not just 1 or 2 of them, but a lot of different ones. So I'd encourage you to think about it, and that we have some resources here for you today. So these are just some commonly used CPT codes under those different categories, right? And again, we have a resource for you that we're going to share. And also, let's go ahead and mention it now, and I'll mention it again at the end. There is a webinar we highly encourage you to participate on June 6th. This is a group that I'm a part of, and we developed this filling and coding guidance document. And we finally talked someone into putting together a webinar on this. And so Health Insight, who now is a part of Quality Core, you guys might know Q Core, they're going to be doing a webinar, and you have actually a flyer in your packet on it. Please, please, please participate on that. I would imagine that they're going to record it and make available afterwards if you can't participate live, but I hope and think that this is going to be a great resource for you all to participate in that. Other ideas for getting to sustainability: optimizing your billable clinical time for your VHC, right? Making sure your VHCs are credentialed, using a wide variety of CPT codes. Maybe you do a little QI project where you're tracking denials from health plans and then using that data, because you can't just say, oh, this gets denied, right? They need to know the actual, like what got denied, why. Like, I know it takes a lot of work, but think about doing a little project for maybe 3 months where you're tracking which codes are denied from which health plans, and then doing some advocacy with those health plans to figure out why and get those codes paid. Simply increasing the number of patients your VHC sees. Some clinics that I go to are seeing their VHC may only see 2 to 3 patients a day. I don't think you're going to get to financial sustainability if that's the case. Also, make sure you have clear expectations for your VHC in terms of clinical versus non-clinical time. And what else? Any other ideas? You can talk more in small group breakout about this. Okay. Oh my gosh, we're pretty much staying almost on time with our agenda, which is a miracle. Okay, so we are going to next transition into small group breakout discussions. Okay, so hold on for just 1 second. What we're going to do is you're going to self-select into the different topics that you want to participate in. I would encourage you, but it's not required, for your clinic team to break up into the different groups so that you're not all at the same one, because later when you come together, you'll have an opportunity to share what you've learned. I'm going to ask each group then to designate a scribe. There's discussion questions that I've put together. We have a sheet of paper that we'll hand out. You can use those to guide your discussion, but you obviously can talk about whatever you want. But you can use those. And then, again, you can report out. Now, here's our breakout topics. We have 4 that our planning committee helped select. But guess what? We are flexible. If there's a 5th burning topic that you want to talk about today, we can totally do that. So, number 1, VHC scheduling templates and workflows. How do we maintain 50% open access, which is one of the Idaho requirements that are also part of Pacific Sources standards. Optimizing same-day VHC interventions. This one might be a good one for PCPs to participate in, because perhaps is there certain language that you're using that makes it more likely when you introduce the idea of seeing the VHC that patients will engage. If we say, I want you to see my mental health provider, that might not be very effective. But gosh, if you're saying, I have a member of our care team, Scott, who's available right now, who specializes in depression, he's able to see you today. Maybe that makes it more likely that patients will engage with that VHC and not say no. So that might be a good one. Also, patient engagement resources. I've seen some pretty innovative work around posters and just some education right now, so that not only are we're all being re-educated in terms of what behavioral health is, but we're also re-educating patients and families about what it is, right? And destigmatizing it and making it routine and helping them understand that this isn't ongoing therapy forever, or this isn't just for people with serious mental illness. This is a regular part of routine care. So maybe you've done some work in this area in terms of patient engagement resources. Number 3, increasing population reach and penetration, if you want to talk a little bit more about strategies for that, and optimizing billing and coding. So number 1 is going to be on this side of the room, if you want to participate in that topic. Number 2 is going to be kind of back in that area. Number 3, back in this area. And number 4 on this side of the room. And is there number 5 that you want to talk about? Number 5? Yes.
So
So we're a small group. We only have 3 providers. We would like to collaborate with behavioral health, but we don't really know where to start. And obviously with a small clinic, we can't really have someone on staff. But we're having challenges in finding anybody in the community whose panels are open, who have same days, who will allow us to call up and say, we really need you to see this patient right now. So just developing those networking and knowing where to start and who to contact for that is something that we're looking for.
Okay. Is there anyone else, and it's okay if the answer is no, is there anyone else who wants to participate in that topic? Oh, excellent. Okay. Topic number 5. We will do that. We can accommodate. We're flexible. So topic number 5, maybe we'll do 4 kind of back in that corner, and then topic number 5 up here. Okay, so there's big sticky sheets that kind of tell you where to go, except number 5. 5's up here, and go ahead and break up. All right. Have your attention for just 1 second. I love that you're already doing your team planning, but hold on, time out for just 1 second. Should I have your attention, please? I love all the networking and conversations. Hold on 1 second. Okay, everyone, we're gonna ask you to sit with your clinical teams, and we actually have a worksheet for you. It's a PDSA worksheet. It also doubles as something that you can use for your PCPCH requirements, right? For quality improvements, you can get started on planning something new, a change, something different that you're gonna try when you get back to your clinic. So first of all, you can each talk a little bit about what you learned from your small group breakout discussions, and then use the PDSA worksheet that we're gonna hand out to develop a plan that you can start to implement, and be prepared to report out on that. We're going to have about 20 minutes for team planning, and then we're going to do a report out and do some wrap-up activities. So thank you for that, and go ahead and commence your team discussion. Okay, let's wrap up your discussion. We'd like to hear from you about what your team decided that you're going to work on when you get back to your clinic as a result of what you learned today. Or also, if you really wanted to mention something that you talked about in your small group breakout discussions that was really a aha moment for you, please feel free to shout that out as well. So let's start over here with Mosaic.
We're going to continue, since we already have about 5 separate PDSA cycles on all the other stuff, we're going to just really focus on the one handoffs for this PDSA. And I will try to remember everything that we talked about. I think there's been a conceptualization that those warm handoffs or same-day visits are really meant to be for crises, and re-educating everyone that that's not the purpose of them, even though that's one of many purposes of them. And then we just talked about some ways to optimize it on the ground to make it easier. Like MA is feeling empowered if they see a screening measure that's out of whack, or during their pre-visit planning to feel free to add on to a same-day visit.
Great. So increasing same-day warm handoffs, and empowering the whole team to be able to proactively identify patients who could benefit from seeing an EHC. Excellent. Who's next? Yes.
High Lakes, our plan is to create a program.
I love that. That's awesome.
Right? So we've got a busy 2 months to apply for the QUIM grant. We've already been interviewing program leads and to get all the workflows in place, and corporate improvement in place. So we've got a lot to do. But this is great. You know, it generates more questions that we need to be asking so that we can. We were just talking about reverse engineering this process, what we want it to look like, and then stepping back into that. So we've got a lot of work to do.
Awesome. I love that you guys are being so thoughtful about it. I think a lot of clinics just like hire someone and they're like, all right, we're good. And then it doesn't exactly work out. And so I love how you guys are really investing in ahead of time, thoughtfully planning so you can be successful. Love that. Who else? Yes. So for St. Charles, yeah.
For St. Charles, we came up with a whole bunch of different things that we want to, but I'll, I'm short, I'll just focus on a couple of them. One is to really focus on helping educate the patients as well as all the other caregivers that are interfacing with patients, from the front desk staff to the MAs to maybe some PCPs, that behavioral health is just an integrated part of everyday healthcare, and it's not some extraordinary thing. So working on posters, flyers, and clinics, as well as standardized orientation for our caregivers so that they understand how integrated care. We also talked about some systemized workflows, so just standardized referrals to the BAC for diabetes, and there's a bunch of other.
Awesome. Great. So a lot of patient engagement and educational resources and some standardized workflows where you're automatically involving the DHC with patients coming with diabetes. Excellent. Who else? Other teams? Yes.
We got a team.
Yep. And you're from La Pine, right? Yep.
The purpose of workflow, so we're having all these agencies
Awesome. So prevention, right? We're getting it upstream. We're destigmatizing the services and introducing it to patients and families before they even need it so that they are more likely to engage later. Love that. Awesome. Who else?
At the Civic Source, we were talking about how to eliminate or standardize some billing barriers. The group that the small group that I was in was specifically talking about a concern of an additional copay if you were adding on a behavioral health consultant visit. Unfortunately, at the Civic Source, we are also siloed between our lines of business. I know talking about this is going to fix it all. Someday, maybe not. Maybe this year or next, but in 5%. So anyway, so we have some, there's some low-hanging fruit and there's some education pieces, and then there's some other kind of longer-term foundational pieces that we need to look at operationally, but certainly wanting to remove any of those kind of key barriers from resource.
Did we miss anyone? Any other clinics? Or does anyone have anything that they want to share? Oh, hello. Yes.
So we're going to make some updates first. A little small portion of them. And then making some changes that more annual visits.
So optimizing some of your fee-for-service billing, and then destigmatizing, introducing more same days, that sort of thing. Excellent. Great. Yes.
We were number 5.
Yes, number 5.
So what we're hoping to do is a small offices who don't have integrated into our offices, just trying to identify resources to give the community taking patients, working with specific source, getting some ideas of the positions that they use, time that we can use, and just really networking with each other as a small practice to help each other. So our step 1 is just finding behavioral.
Yeah, that's great. It's going to take all the different steps, right? From screening and identification to providing integrated behavioral health in the medical home to referral to specialty, right? It's going to take all three of those working together to get to this. So I love that you guys are a resource for each other. And thank you for being here. Yeah.
And on this digital health improvement plan, work group that determined what the project is that will be funded for next year, that specific issue is so bad in your mind is how do we effectively identify intervening primary care as much as we can, but in most cases what we do need for specialty health services. How do we really monitor that, the referrals that happens while the patient is in a specialty health environment, the bidirectional communication, the primary care and specialty health during that time, and then closing the loop of rebuilding that patient having primary care for ongoing treatment or chronic treatment that condition. So there's a lot of work to be done there, and do that well, probably shorten those treatment episodes outside the primary care level. So that is specifically scoped in the work with that technical assistance position.
I definitely, and I'm from the health and the co-team, the ideas they were talking about were identifying if we really think about child checks to always insert ourselves into it, into development, the behavioral health estimator. And then also we have several pathways where automatically triggers abuse and control right now. I think about that is going to be increasing our team, so we're talking about those other pathways we want to add.
Great. Thanks for that. I hear lots of getting, right, like working upstream, getting preventive, and destigmatizing and educating patients and families. So that's great. Anything else that anyone would like to share, either about your team clinic discussions or the small group breakouts that were an aha for you, or still questions that weren't fully answered or solved here today, besides billing and coding? We know that that's a thing. Financial sustainability, we'll work on getting there. But anything else?
I think I mentioned this to you already, but in the group 3 that I was in, what resonated with me was folks saying that it was really pull referrals versus push referrals from PCPs that were really helpful. So doing chart scrubbing, identifying people ahead of time with puddles, kind of being more proactive and kind of pulling the referrals out were more helpful than waiting for a referral from an PCP.
Yeah, I like that language, pull versus a push referral. Yeah.
That would incorporate into the patient registry. Maybe if you have a partnership with Pacific Shores or Member Insight Report, shares claims data with you. Really have some understanding of who the high-risk members or patients are, they're misstratified, and say, okay, we want to get that subset, put them on the registry, have these metrics that we're going to follow for patient 9, CAT 7, scare, whatever it is. We're going to track that and make sure our agencies are involved throughout that until we get to the scores we want.
One thing that made me think of, I'm shy that I work with members here in Charles. I feel like our clinic has changed a lot in the past 3 years at getting this closer, right? And one thing this made me think of today is the culture needs to change so much between the staff. And one thing that we've done is during the warm cleanup, I won't just come in and say, oh, hi, hope to see you again soon. You know, we will actually model that up between me and the medical doctor as far as what's going on with the patient, what the medical doctor will talk about, what she's thinking to help with this patient, what's my feedback on it, and we'll do that right in front of the patient. And I really think that shows them like we're a team together. It also gives them opportunity that their main doctor is in support of their referral. So I just think that's really cool. Like we interface a lot more.
That's really interesting. I love that. Thank you for sharing that. Because I've been a patient where you feel like, the doctor says one thing and then somebody else comes in the room, and it was clear that information, there was some sort of breakdown in that information, and so I love that.
And it makes the person more comfortable and they're more likely to return to like that and talk with them for with their provider.
Excellent. Yeah, that's great. Love that. future learning opportunities. And before you leave, we do have an evaluation form. We want to hear from you about what went well, what needs improved, other topics for future collaboratives, as well as it's required for the OHA funding that will complete the evaluation. So thank you for doing that. But June 5th, are we in the same location or is it a different location? Same location. Okay, June 5th. We'll see you all here in about a month for the medication-assisted treatment. We have a wonderful guest speaker coming. And then please put on your calendars the webinar. There's a flyer in your packet for billing and coding. Save the date for our September collaborative. It is September 18th. If you're able to block off your calendars, please do that. Then the December topic is collaborative care. And if you have other suggestions for topics, please write them on your evaluation sheet. I want to give a special shout out to the Central Oregon Health Council staff that have been so amazing. And thanks to Pacific Source, who's also been incredibly engaged and really committed to moving this work forward. And that's not every health plan in Oregon is there. I can tell you that. So your evaluation is the last sheet in your thing. And look, you even get 5 minutes to complete your evaluation and do some networking. So thank you everyone for being here. I really appreciate it.